Okay, so these slides should go pretty fast because we've already reviewed this. So coronary artery disease. So we were talking about atherosclerosis and that progression of plaque formation within a coronary artery. And atherosclerosis is the cause of coronary artery disease. So if it's in the legs, we'll call it peripheral artery disease. If it's in the heart, we'll call it coronary artery disease. If it's in the brain, we'll call it cerebrovascular atherosclerosis. And it's where you actually deposit, and those images will probably help you on a few slides back, of cholesterol and lipid, mainly in the intimal wall of the artery, and it gradually enlarges, forming a fibrous plaque. And if the plaque doesn't rupture, you might get symptoms of reduced blood flow, trying to get through that blocked vessel. But plaque rupture leads to immediate symptoms of blockage, of complete blockage, or a very high degree of blockage in the artery. And we'll talk about that in a minute. So it's that progression of a fatty streak as a young person that then, if you continue with a unhealthy lifestyle, smoking, fatty foods, it will gradually lead to plaque formation and enlarging fibrous plaques. Now, as I said before, if it just leads to a gradually enlarging plaque, and it starts to occlude 60 to 70% of the coronary artery, then you're going to get a symptom called angina, where as every time you exert yourself or walk up a hill, at a certain point you're going to get chest pain, shortness of breath, that requires you to stop, because it's basically the lack of oxygen getting to that part of the heart that's giving you ischemic chest pain, angina, lack of oxygen, okay? If it suddenly ruptures and you get that thrombus that your body forms on top of it because it thinks it's doing a good thing by trying to form a thrombus on top of the rupture, which in actual fact it's causing more trouble, then you'll develop what's called acute coronary syndrome. And we'll get into that much more, what acute coronary syndrome is. So risk factors for coronary artery disease. I mean, we can basically think of this as risk factors for atherosclerosis, because that's really what coronary artery disease is. It's just in any vessel, in any artery of the body, these are risk factors for atherosclerosis. So family history, sure. If you have brothers or sisters and mother, father that have had coronary artery disease or atherosclerosis, then you're at risk for developing it, especially if they were to get this condition in their 30s or 40s. Your age. So males over 45, females over 55 are more at risk for having coronary artery disease from atherosclerosis. Now males males often get heart disease younger because estrogen is protective. After menopause, women catch up very quickly in terms of coronary artery disease, angina, heart attacks, and they become basically equal. So males over 45 and females over 55. Heart disease is the #1 killer of women and men. So 1 in 3 people will die of some form of heart disease. Women are less likely to call an ambulance when having chest pain, whether it's minimizing the symptoms or they're unusual symptoms that don't fit exactly what they think of as having a heart attack or angina. They're less likely to call an ambulance. The next slide is women often have different symptoms. So women may present with neck pain as their symptom of angina instead of chest pain. They may present with jaw pain. Now, that's not to say that men can't present with this as well. It's just that women can often have atypical symptoms. So what's the classic symptoms of angina from coronary artery disease? Well, it's typically chest pressure or chest heaviness, so central chest heaviness. You can have shortness of breath with it. You can have radiation to your left or right shoulder and arm. You can have radiation up to your neck or jaw. And typically with angina, this will settle and go away with rest. With other blockages, such as acute coronary syndrome, it will have different symptoms, but it doesn't necessarily go away with rest. And the last factor that can cause women to present a bit later with coronary artery disease, even though they have it, is that healthcare practitioners tend to have a lower suspicion of heart disease or angina in women compared to men. It's just a bias. So all these factors can lead to delayed diagnosis or misdiagnosis in women. Okay, so on the other slide, we spoke about risk factors that are not modifiable. So your age, unfortunately, is not modifiable. Your gender or your sex, family history, they're not modifiable factors. What is modifiable are things that you can do to reduce your risk of coronary artery disease. Diabetes. Well, diabetes is modifiable because you can prevent most diabetes, since most diabetes is type 2 diabetes. And most type 2 diabetes is from our diet and from obesity. So unhealthy diet and obesity. Not all, but the vast majority of type 2 diabetes is caused by that. So you can have a huge impact in controlling diabetes or actually eliminating it if it's type 2. And look at this is the largest risk factor for coronary artery disease is diabetes. So good control of diabetes, or even better than good control, is through lifestyle, diet, and weight loss, is actually controlling diabetes with normal blood sugars and not even requiring medication. So that's hard to do, though, for many people. Cigarette smoking, high risk because it damages the arteries and leads to coronary artery disease and atherosclerosis all over the body. Chronic hypertension that needs lifestyle changes and sometimes medications. Cholesterol and lipid issues. So high certain lipids in your bloodstream like LDL put you at risk for atherosclerosis. Now this is partly determined by diet and partly determined by how your body makes cholesterol and LDL and HDL. So, but it is controllable with your diet, exercise, and also with medications. So it's not the biggest risk factor, but we list it as a modifiable risk factor. But definitely these are the big four: diabetes, smoking, hypertension, dyslipidemia. Other ones would be physical inactivity, obesity, are risk factors for coronary artery disease. So anything that you can think of that's damaging and forming plaques within arteries. So I'm not going to spend too much time on this slide, unquantified correlation. These are just contributors. If you have a diet very high in carbohydrates, I always think of those huge, 1 gallon pop containers filled with some kind of soda. That your body just takes all that sugar and it'll convert it into fat if it doesn't need it as energy at the moment. So um, a diet very high in refined sugars, like simple sugars, can lead to coronary artery disease. Obesity, we mentioned. Inactivity, sedentary lifestyle makes sense. Women postmenopausal, they're not producing estrogen anymore, which was very protective for coronary artery disease. So their risk goes up postmenopausally. There's a certain little there's a chemical in the bloodstream called homocysteine that we can measure. We don't do it very often, but if the level is very elevated, it's a risk factor for coronary artery disease. By the way, the treatment's very easy. It's just folic acid. And folic acid you may have heard of before. It's used as a prenatal vitamin, but it can be used to reduce homocysteine levels in the bloodstream. Not a big factor there though. Chronic inflammation in the body from a variety of different diseases. Well, I've I've repeated over and over again that it's damage to the endothelium that causes the initial fatty streak or the intimal injury that leads to atherosclerosis. So if you have chronic inflammation and antibodies and antigens flowing through your blood, such as in lupus, rheumatoid arthritis, many autoimmune diseases, you're at higher risk for coronary artery disease. Chronic stress, depression, anxiety, um, releases different types of hormones and chemicals into the bloodstream that puts you at risk for coronary artery disease. Hyperthyroidism, which was basically stimulating the heart to beat faster, to beat harder, is a risk factor for coronary artery disease. Poor sleep cycles. I shouldn't mention this to students, but lack of sleep, sleep apnea, where you're continuously waking up through the night, or chronic insomnia, where you're not actually getting a good night's sleep for many years, is a risk factor for coronary artery disease. And lastly, your diet, which I mentioned in the first one, but a diet high in saturated fats, which is typically animal fats, and very high in refined sugars is also a risk factor for blocking up the coronary arteries with atherosclerosis. Okay, so let's just carry on here. Coronary artery disease is really important because really that's the blockage of the coronary arteries is what's going to have you understand angina and heart attacks and heart failure and all the other things that can happen with the heart, because the coronary arteries, atherosclerosis of them is unfortunately a very common process in developed countries, partly because of our diet and our lifestyle. So very important disease to understand. So this slide just goes through it again. I'm going to skip the first two because I've gone over it, number 1 and number 2. Let's just talk about number 3. So you've gotten to the plaque stage where it's gradually enlarged within the vessel, and there's what's called a cap or a plaque on top of this this collection of fat and lipids and cholesterol that's sealing it away from the bloodstream. Okay, so it could enlarge and enlarge and enlarge and cause flow disturbance within the vessel and lead to a lack of oxygen getting to parts of the heart, which would be called angina, especially like when you're exerting yourself. And that's stable angina. So I do a certain activity, like I walk up a hill, and I get chest pain at a certain predictable level of exertion because the heart wants more oxygen to work when it's beating faster and harder, and I can't provide it. So I get ischemic chest pain called angina, and it goes away when I either take a nitro spray and sit down. If that plaque ruptures, I get a complicated plaque, and that leads to acute coronary syndrome. And acute coronary syndrome is made up of a few conditions. So the plaque is now broken open, and your body is forming a thrombus on it, which leads to more blockage of the artery. And if it doesn't completely occlude or block the lumen of the artery, you can get something called unstable angina, where you're now getting unpredictable bouts of chest pain. You're sitting down at rest, you're getting chest pain. You might be going for a light walk and you're getting chest pain, and it's suddenly the nature of how you were getting angina, stable angina before, has completely changed. It's unpredictable. It's coming and going without having to exert yourself. So that's now become a totally different condition. That's become a ruptured plaque. And the reason why it makes it into the acute coronary syndrome is this is more urgent and emergent. You need to go to a hospital when this happens. You haven't actually infarcted or damaged any myocardium. This unstable angina is warning you that you are really critically short of oxygen to the myocardium, to the heart muscle. If it were to block a bit more, then you would get what's called a non-ST elevation MI, an N-STEMI. And that's where a part of the heart has died, but it hasn't shown up as an ST elevation on an ECG. Okay, we might have other changes on an ECG, but not ST elevation, which is a particular type of myocardial infarction. Okay, a type of heart attack. So an N-STEMI and a STEMI are heart attacks. And why are they heart attacks? Because both of them have some degree of permanent heart muscle infarction and damage. So an N-STEMI just means that it didn't show up on ECG as an ST elevation MI, but it did release what's called troponin, which is the enzyme that's released from dead myocardial cells into the bloodstream. So we will pick up a positive troponin in an N-STEMI or a STEMI. Okay, so now let's talk about STEMI. So a STEMI is ST elevation MI. So do you release troponin into the bloodstream? Yes, because it's a myocardial infarction. Is there ST elevation on the ECG? Yes, and hopefully we can get into this a bit more, but there's changes where a section of the ECG, and you can go back to the slide that shows your typical P wave, QRS, and then T wave, and look for the ST segment, and that gets elevated in an ST elevation myocardial infarction. And the difference between the two is an N-STEMI is important. Yes, you've had a heart attack. Yes, we need to treat it, but it's not emergent that we have to open up that vessel right now. There has been damage to the myocardium, to the muscle, usually much significantly smaller compared to a STEMI. A STEMI is a complete total blockage of that coronary artery, and a significant portion of the myocardium is dying. And if we can open that vessel fast enough, you can save some of the myocardium, some of the muscle. So they're both heart attacks, but they're different types of heart attacks. In actual fact, a STEMI is a heart attack that goes right through the thickness of the myocardium. It's called a transmural infarct. It goes right through the full thickness of the heart muscle. An N-STEMI is not a full thickness heart attack or infarction. It's a partial thickness. So the STEMI is emergent. We either have to give something to open up that blood vessel, such as a fibrinolytic, or we send them right immediately to the cath lab. An N-STEMI is not emergent. We still need to treat them with blood thinners and other medications, but they don't need to be rushed off to the cath lab this minute. So the fatty streaks that, as I said, can be seen in autopsies of teenagers or 20-year-olds, very commonly in North America or developed countries. They are potentially reversible if you were to completely change your lifestyle and avoid all modifiable risk factors. There is a potential to reverse some fatty streaks. Unfortunately, in North America, we're seeing fatty streaks develop at an earlier and earlier age because of our diet and our sedentary lifestyle. This progresses to the next stage, which is a fibrous plaque that we've spoken about, and this will give you some information about the lipoproteins. So lipo is fat, proteins is protein. So lipoproteins such as LDL are now forming this fibrous plaque underneath the endothelium, and the plaque is formed by a strong collagen layer because it really doesn't want to rupture open so that the blood sees what's inside it, because then it'll form a thrombus on it. So really, if it doesn't rupture, the fibrous plaque will gradually just cause narrowing of the vessel, slowly over years. So again, we'll just briefly talk about the complicated plaque. So this is where you may have had some angina symptoms with a stable plaque. When you exert yourself to a certain extent, you'll get anginal symptoms of chest pain, shortness of breath, maybe some radiation to an arm that's relieved very quickly with rest and a nitro tablet. Acute plaque rupture, a complicated plaque, is something that happens suddenly. Unfortunately, this plaque has broken open and exposed itself to the blood, which is now going to cause the blood to clot and occlude the artery. So platelets will recognize this plaque rupture as something foreign, and they'll stick to it, and then they'll send a signal to the coagulation system to form a thrombus on top of it, and this will very quickly cause occlusion of the lumen of the coronary artery. And as the lumen becomes more and more narrow, if you're lucky, you may develop unstable angina. And I say lucky because you haven't actually infarcted. You haven't killed, the myocardial cells haven't died yet. They're ischemic, and you're getting symptoms of unstable angina, but they haven't died yet, as compared to an end-STEMI, which is a partial thickness infarction of the myocardium and release of troponin into the bloodstream, or a STEMI, which is a full thickness infarction of the heart muscle in a certain location. So from the outside to the inside, myocardium has infarcted in a STEMI, and we see it on an ECG as ST elevation MI. Okay, so this next slide is just really a diagram showing you plaque buildup in one of the coronary arteries. And not only is it a plaque, but it's a ruptured plaque. So now you're seeing the red blood cells and platelets further occluding the entire vessel. That's going to lead to an infarction. So whether it's an end-STEMI or a STEMI, infarction means death. So ischemia means lack of oxygen. Infarction means I've had a heart attack because by definition I've had cell death. And how am I picking that up? With troponin release into the bloodstream.